Good afternoon, everyone. I'm Dr. Aishwarya, Junior Resident from Jubilee Mission Medical College, Thrissur, and I'll be your host for this session. On behalf of Transfusion Medicine Academic Society, I extend a very warm welcome to all of you to today's webinar. We are delighted to have your presence for this academic session. It is my privilege to introduce our chairperson for today's session, Dr. B. Abhishek, MD in Transfusion Medicine, DNB in Immunohematology. Sir holds various degrees like MNAMS, PGDCR, FAIMER, and Sir is certified in cellular therapy from AABB. He is currently additional professor and head of the Department of Transfusion Medicine at JIPMER, Puducherry. Dr. Abhishek has contributed extensively to the field with over 70 original articles and 20 review papers, authored books, and has been honored with the Young Scientist Award ISTM 2019 and the HD Shourie Award at ISBTI 2021. We are privileged to have him chair this academic session. May I now request Dr. Abhishek to kindly introduce our esteemed speaker and take the session forward. Over to you, sir.
First of all, congratulations to Dr. Ankit Mathur and his team for the fantastic feat achieved. And also, of course, team us for catching him at the earliest to have a webinar of this expenditure in the sense of knowledge and getting it across for the people whom are interested to know that. So Dr. Ankit Mathur needs no introduction to the immunohematology fraternity, but however, if somebody new people have joined, I would like to tell it's a privilege to introduce Dr. Ankit. He is the additional medical director at the TTK Rotary Blood Bank or Blood Center. He is also the transfusion medicine and transplant immunology expert or consultant. He has completed post-graduation in transfusion medicine and diploma in tissue banking from NUH Singapore. He also holds a fellowship of transplant immunology from Ohio State University. He is the scientific secretary of Asian Association of Transfusion Medicine. He is also NABH assessor and member of most of the transfusion associations like ISBTI, ISTM, AATM, and even the ASHI. And not only is a member, he has contributed significantly to various capacities in most of this association. So without taking much time, I would call upon Dr. Ankit Mathur to take on the center stage.
Thank you so much, Abhishek. First of all, thank you so much, Transfusion Medicine Association, Academic Society, TMAS, for giving me this opportunity to talk and discuss my experience, whatever we did something here about the new antigen which we found, and whatever we do here in Bangalore about rare donor program. I would like to share with you. And first of all, can you just help me with this? Are my slides visible?
Yes, your slides are visible.
Yeah. And I'm just putting it on slideshow now. Just check whether it's working. Is it on slideshow?
It is on slideshow, yeah.
Yeah, it's working right now. And change, when I do the change, is happening?
Yes, yes.
Okay. Thank you so much. And my voice is clear?
Yes, your voice is clear.
Okay, thank you. So once again, thank you so much for this opportunity. And I would like to discuss something about this novel antigen finding which we have here in Bangalore, and whatever some little work we do in the area of rare donor program. So you might have seen some or heard about some the newspaper, like somebody has got some woman had got a antigen which was never seen earlier. So when we found, we wanted to just project it to some local newspaper But somehow this news over a period of time gone beyond our control, and many people, many media houses reported in different ways without our knowledge and controls. And some people have in fact distorted this information with a lot of non-scientific, or actually you should say nonsense, we have added, and that put the fancy news somewhere. But anyway, with this whole information, immunometallurgy came into the picture somehow, and the transmission immunometallurgy and blood group antigens somehow came into the picture. And then even my neighbor started asking, ये ABO के अलावा भी कुछ blood group कुछ होता है क्या? So at least we could able to sensitize people that there is something called red cell antigens, and where we really need to find out about it. So coming back to this case, which we had last year sometime from RL Jalapa Hospital, thanks to Dr. Subhashish Das and his team, who were prompt enough and in fact aware enough to at least report this case and send to the center wherever we could do something, or at least we could forward to some other center. So this was a case of a 38-year-old female patient admitted to this hospital for some cardiac surgeries. She had atrial septal defect, and it's a planned surgery. She was admitted to this hospital for this surgery. And when they wanted to transfuse this patient before surgery, 1 or 2 units, and they found this blood grouping was quite clear, O negative, but none of the unit at RL Jalapa Hospital, they found it was cross-match compatible. So they sent sample to us, and then for further testing, whatever we can do. So when we started working on this case, we found blood grouping was quite clear. It was O negative, forward reverse was matching. And we found antibody screen when we did, it was positive for all three cells, cell number 1, 2, and 3. And but the DCT or auto was clear negative. And also we did H-lectin test, which was H-lectin test was also the positive. So we are dealing with the case which is no auto, no Bombay, and reactivity in each and every cell. So this was the background which we started. So similar information again in this picture now. If you see, this case has all three cell positive and DCT negative and H-lectin positive. So with this background that we started, so we have in this situation, whenever you have a two options going around, like either you are dealing with the case with the multiple antibodies, or you're dealing with the case with the one antibody but reacting with almost every cell whatever we have. Just for our knowledge, we wanted to find out how strong this antibody is. So we did the titer of this case, and we found titer was quite high in this case. It was 256. So in this situation, we also tried to do similar tests with the tube also. Like whenever we have this situation, sometimes this reaction, the pen reactivity could be because of the reagents, could be because of the preservative in the cells, could be because of the technique specific also. Sometimes the moment you change the technique from column to tube or solid phase to tube, you see the reaction has gone. So this could be because of some technique specific. So we try to do with the different techniques and different temperature, whether the reaction remains the same or if there's any change. So when we did with the tube, still reactions remain the same, at least at the A and G phase, and it was 3+, 3+, and 2+, which we found in the column. So we almost decided we are dealing with a true antibody. It's not just a false reaction because of method or some the preservative reaction or something else. Then we did an identification panel, whatever we had, the panel A. If you see, the reaction pattern was same with the each and every cells from cell number 1 to 11. And so we were almost sure that we are dealing with the antibody against high frequency antigen. Just for the hope, we thought, okay, let's try with some other panels also. So whatever panels we had available, the good quality cells, we tried to do with the react with every cell, and we found that this was reactive each and every cell. And meanwhile, auto was keep on coming negative. There was no problem of auto antibody in this case. So with this background, when we did antigen extended phenotyping of this case, and sometime, this case could be of D dash dash or some null. So whatever possible serology finding which we could do at our center, we did. So we did RH phenotyping, and we found that this is not D dash dash or RH null. We did Duffy testing or KID or MNS. So we were sure we are not dealing with Duffy null. We are not dealing with KID null. This is not U negative phenotype. So whatever we could do from our side from serology testing, we completed this testing at our end. Meanwhile, we were also trying to do cross-match with the family donors. So we sent our technician to the family. Like this family has, the relatives were in and around the Kolar district, so various villages in Kolar. So one of our technician went to their houses one by one and collected almost 18 samples from the family, and we did cross match with the all they and these families were, and they had the a marriage within relationship, continuous marriages they had. So this the husband of the this patient was also related. So each and every family members were quite related to each other. So we collected 16, 17 or probably 18 samples. None of the sample were compatible with the patient. And meanwhile, the surgery, they could manage the surgery without transfusion, and everything happened nicely to the surgery patient point of view. But we thought, let's work out the sample and whatever we can do. So with this proper basic information, this case patient is just a revision again. The patient is O negative, pen reactive, TET negative, auto negative, H lectin positive, and this is the extended phenotyping. So with this information and the impression, this is a suspected case of high frequency antigen, antibody against high frequency antigen. And we sent this information or all these samples to IBGRL in UK. And the people who sent their samples to IBGRL, they might know they are very strict in the sample. I mean, the receiving side and the documentation side. So they take first of all long time to receive the sample, and then after that they take long time to give the report also. So we sent the sample sometime last year in February or March, and this year's almost after 1 year we got this report from Nicole, who had this IBGR lab, Nicole Thrompton, and she sent me this detailed report and the email. And in the email, it was written, this is look like a novel antigen which has not been reported anywhere, and attached is the report. So when I first saw the report, it took at least I read it 10 times, then I had some glimpse, okay, likha kya hai? So some sort of information which was written is absolutely, I was blank what is written here. So it was very difficult to understand this report, and then understanding the report and putting the same thing in the Google and finding what is this, what's the meaning of this word, what's the meaning of this sentence. So this report was really complicated. So this report, actually a couple of reports came from IBGRL together with the patient's 2 reports, one report from the lab like IBGRL lab, another report from there, the molecular like sequencing lab. So these 2 reports, and with these 2 reports, couple of other reports of the family members. So we sent the patient sample like serum sample as well as EDTA and DNA sample, and a lot of other relatives samples also we sent. So everything, all the reports came from IBGRL. To simplify everything, I have just noted down a couple of the points. So first information from this report was gathered. This antibody was related to Kromer blood group system. How did they find this? This is Kromer blood group system. So any people who don't know how these reference lab works, they have all these null cells preserved. So whenever you have a case of this, so second or third, I will discuss the protocol, also the testing protocol. Third or fourth step is to check with the available null cells. So all these people, all these centers, they keep these null cells to find out which blood group system this antibody belongs to. So this center had the chromer null cells also preserved, and they found with the chromer null cell it was negative. So one information they got, okay, this looks like a chromer blood group antibody. And another unique, and the people, and when I came across about the system, I had absolutely zero idea about Krumer's blood group system. So people or students who do not know about Krumer's blood group system, do not worry. This is a really uncommon thing to work on. The Krumer blood group system is actually a blood group system or combination of some of the high frequency antigen and the low frequency antigen. And this blood group system is, or the antigens are present on a protein called decay accelerating protein or CD55. These antigens are present on this system, and this like I said, combination of some high and some low frequency antigen. But the problem with the system is this is the clinically significant antibodies. Whatever antibodies anybody develop can cause transient reaction. But interesting again is they do not cause HDFN, because these antibodies do get absorbed in the placenta while transmitting from mother to fetus. So fetus do not develop any hemolytic disease, even if mother is having positive about this antibody, and the fetus is having this antigen. So this information was actually, I was unaware about this information, because this patient had a couple of, I think 2-3 pregnancies and never had any hemolytic disease of newborn. So no problem during the pregnancies and the post pregnancy also. I mean, the baby had absolutely no problem. So this information is useful. So first of all, and another information I want to share here is, so they have this protein, so they could neutralize this antibody with the help of DAF protein. So with this help of two information, whether first is a recombinant DAF protein and the help of null cells, they could identify, yes, this is a antibody from the Kromer system. So next step is, once you identify this antibody belongs to which system, then you do the sequencing of the sample. So you have a DNA available, you put your DNA on target gene sequencing. Now you don't have to sequence for KEL duplicate, you have to sequence only for Kromer. So they started sequencing for Kromer for all the sample, patient sample and the relative sample. When they did this, the sequencing of this patient sample, they found this patient has a homozygous missense mutation in exon number 6, this of CD55, which is this protein. This protein CD55 has some 11 exons, and this mutation was on chromosome number 6. And this mutation, because of this mutation, this patient has a loss of a novel high frequency antigen. So all of us do not have this mutation. So all of us have these high frequency antigen. And this particular patient had this mutation. So she lost this high frequency antigen and developed this antibody over a period of time. When they found, after the sequencing, they found whether the sequencing data available in the database or not. This sequencing data was not available in the registry at ISBT allele table, as well as in the genome database also. So IBGRL level, they were almost nearly sure whether this, this mutation is, or this antigen is the first time they are dealing with. But there was another trick in this case. The amino acid substitution, which happened after this mutation, which was very close to another antigen from the Kromer system, which is called CRAM negative. So they thought maybe they are very close, so maybe they are together causing the same antibody. So when they did patient typing of CRAM particular, they found it was positive. And with the CRAM negative, this plasma of this patient was giving incompatible result. So they were sure that so with this help of this information, they were sure they are dealing with two different antigens, the CRAM, which was detected earlier, and this one, which they are dealing with now, is a new one. So with this complete information, they said this, they have assigned a novel allele. And interesting was the two of other family members also had this mutation, but on heterozygous phase. So this mutation was going around in this family, but for some reason this patient had at homozygous, so she lost this antigen and developed this antibodies. This was again a part of, this was a mutation, whatever she developed. This was written in this IBGRL report. And again, the repetition of what I just now explained to you. So first information is we are dealing with the high frequency antibody against high frequency antigen. Second information is this antibody belongs to chroma blood group system. How do we know it's a chroma blood group system? With the help of inhibition test of from recombinant DAF, and second from the chroma null cell. And how do they get chroma null cells? The chroma null is a, it's a DAF. There's a disease called Chapel syndrome. So the patients who do not have this protein, like CD55 deficient individual, they have a disease called Chapel syndrome. And this Chapel syndrome has something related to like coagulation, enteropathy, and something. So this is a known fact. There are some individuals available. It's a rare genetic illness, but there are people available who do not have these chroma antigen at all. So these the reference lab, like I said, they keep these null cells preserved. So this patient sample was found compatible with the chroma null cell. So they were sure this we are dealing with the chroma antibody. And then they did this sequencing for this case, and they found they are dealing with the novel antigen. So again, the repetition, what is chroma blood group system? This is from DAF protein. And this is a chroma system is, like I said, combination of high frequency. 21 antigens are in this high frequency, and there are 3 are low frequency antigen in this system. So this was a conclusion given by IBGRL, and they discussed with us, okay, this is a conclusion which we are finding. Do you agree with this information or not? So of course, we will agree for this information. This is a mutation in this case, and this patient is having homozygous mutation, and this is a novel high frequency antigen, and distinct from a CRAM antigen which was detected earlier. And this information was sent to ISBT working party of red cell immunogenetics and blood group terminology. This working party received this information from IBGRL sometime in March, April, and then in May 25 this year, 31st May, they released this information and updated information. And meanwhile, they asked, like IBGRL asked us what name you want to give to this novel antigen. So the 2 options were given, and we were okay with both the options. One option was CRIB, Cromer India Bangalore, or Cromer Antigen Bangalore, CRAB. So I personally liked, as we all are very pro-Indian and pro-patriotic. So I thought, okay, I also should be in the name. So finally, this was agreed by IBGRL as well as ISBT. So it came in their list sometime in May, and CRIB became a new and the 21st antigen of chroma blood group system. So this is all about this particular case which we found, and I discussed just now. Now let's discuss something about what actually happens in this cases when we found any high frequency antigen. It might take another 10-15 minutes more. Hope that's fine. If anybody has question about this particular case, you can note down. After 10 minutes, we can discuss same thing again. So coming to this,
before we proceed,
yes,
just a clarification so that everybody understands. So you found a phenotype which was negative for an antigen, CRIB, correct?
So Abhishek, just for again the clarification, if people have confusion. So we could not do any phenotyping for chromer.
Correct.
Right. So we did phenotyping for all the major antigens, whatever we see in our day-to-day lab, like
No, no,
RH,
no.
cal have.
Correct. I understand that. What I was telling
Yeah.
is, here in this patient, it was the antibody that you discovered, correct?
Yeah. Yes.
For a phenotype, and that
Mhm.
phenotype was also not described till now, correct?
Correct. So all these, Abhishek, what happens whenever, how do we detect any novel antigen? Everywhere, whenever you detect any novel antigen, it is always detected through a patient who developed
Correct.
these antibodies.
Correct.
Right. So otherwise you cannot go in the population, do the type testing. So what happens? So this particular patient, we all have this chromer antigen like CRIB antigen. This particular patient did not have this CR. Now we can retrospectively, we can describe this case now. This particular, we all have CRIB. This patient, her fortune किस्मत ही खराब है अभी क्या करो. So now CRIB did not, she did not have this antigen. Therefore, she developed these antibodies. And these antibodies, when you keep on detecting, okay, from where these antibodies come, from where this antibody has come, and then do the genetic analysis, you find she developed these antibodies because she did not have an antigen, which is high frequency antigen. Am I clear now?
Yeah, I think that is what exactly I wanted everybody to understand that. So,
Okay. Anybody has question about any student, PG student, and any question, please ask anything if you have. Let's take anyway. I think now we can take a 2-3 minutes for questions now itself. People might forget the questions again. Shall we, Abhishek? Is that okay?
yeah, I mean, I will
If
just.
anybody has question, can ask now.
There is
About
Yes, sir.
the
Good morning.
no, no, no. I think we'll ask them to write in the chat box, otherwise it will be a chaos.
okay. Okay, fine.
So somebody has asked at the International Blood Group Reference Laboratory, what is the protocol for serological testing for further workup after 11 or 20 cell panel, whatever it is?
For some reason, I can't see the question in the
chat box.
Please. It's my chat box. Shall I stop sharing?
No, no need. The question is, like, what is their serological testing protocol after, like, say 20 cell or 11 cell? Do they have?
Okay, I'm just going to describe this protocol now.
Okay.
Anything else about the case?
As of now, nothing. I will update you once I see something.
Sure. So now, for the students, what is this high frequency antigen is? And the international definition for high frequency antigen is, or you can say the rare is, I mean, anything which is lacking in 1 in 1,000, which is called rare blood group type. So your 999 people will have this antigen, 1% will lack. So this is the international criteria of rare blood type. But they have also written, I mean, they have also the guidelines are given like this. It will has to be described from population to population, from center to center, and from countries to countries. So we cannot go by the definition given by Europe or given by America. We can have our own criteria of defining high frequency antigen or defining a rare blood type. So this is just a basic information. There are good number of not good but reasonable number of literature available about the common high frequency antigen. This information from the Asian some paper. These are the common high frequency antigens, or you can say the rare blood type. Bombay in the Asian groups is the top in the list. Bombay blood group. Second is our D which is RH17, RH null, RH null type, which is RH29. P null is common, KPB is common. So these are the common in Asian population. This is from a German. Sorry.
Excuse me, sorry for interruption.
Yeah.
Sir, can you please make a slideshow?
Slideshow. Sorry. Yes. Is this okay now?
Not yet.
No, sir.
Yeah.
Now.
Thank you.
Now.
Yes.
Okay. This is from a German article, which where whatever in Germany or thing in European population, they found the high frequency antigen, or you can say the rare blood type like KPB, Well, Lutheran, Cartwright, Colton. These are the common in we can say Caucasian population, which they found as a rare blood type. This was a report published by Dr. Joshi sir, Sanmukh Joshi sir, quite long back, at least 10 years ago. I think 2014 or 13, this article was published, and he has reported from India what are the rare types of blood types we have. So Bombay is in the first in the list. D dash dash, we all know. INB, Indian blood group system, INB negative is another one. He has reported one from Colton blood group system, and MG. All these are the reported by Dr. Sanmukh Joshi quite some time back. In last 5-6 years, NIH also has gathered a good number of data of rare blood type. Even if last year Dr. Swati presented it in some conference, 5 cases of INB negative, 2 cases. Out of these 5 cases, 2 cases were from our center from Bangalore, one from Calcutta, maybe 1 or 2 from other centers. But there are good number of data available of rare blood types in at NIH, maybe published, or I don't think they have published as of now. So coming to how do you have a suspicion of, yes, you are dealing with the rare type or an antibody against high frequency antigen. For the students, if you have a case where you feel 3-4 things together, pen reactivity means your sample is reacting with every cell. All cross matches are incompatible. Your auto and DCT are negative. With this basic finding, if you have, you should have a suspicion of, yes, you might be dealing with a case which is antibody against high frequency antigen. So what are the differential diagnosis of this pen reactivity? Yes, if it is auto, yes. So we have to be very careful. Auto should be clear negative. If auto itself is positive, you cannot say it is antibody against high frequency antigen. Another differential diagnosis could be multiple antibodies. So so there are so many antibodies in this patient. So it's finally end up reacting with each and every cell. One cell it is reacting because of small s, another cell which is reacting with small e or something like this. But this patient is having multiple antibodies, but reacting with most of the cells. So pen reactivity. But the difference what you see here in pen reactivity because of high frequency antigen, your reaction pattern or the strength will remain the same. Like in this particular case, if you see the each and every cell, it was reacting with 2+. But if you have multiple antibodies, you will see pattern like one antibody will be weak, one antibody will give more strength with the double dose cell, one antibody will given less reaction with single dose. All these different strength you will see. Some cell 4+, some cell 2+, like this. So then you will have a suspicion. I am not dealing with the high frequency antibody, but I am dealing with the multiple antibodies. Another caution you should always have, yes, this could be technique specific also, and this is not theory. In practice also, it happens many times. This I'm telling you from our experience. Many times your sample react with the preservative used by the cell. So in the commercial cells, which we use 11 cells or 3 cells, they use some preservatives. Some proteins, whatever the patient has, they react with the cell and give positive reaction. So you should try your testing with the tube as well as with the fresh cell. And sometimes it could be gel specific, like the column specific, sometimes could be solid phase specific. So it's always good to change your testing platform from your automated or the new technique to the tube, or tube to some other technique. All these things you can check. Another problem which we all know, like we are facing with some anti-cancer antibody drugs, like which is specifically daratumab, which is give pen reactivity everywhere. So we should always have a history of the patient, what the diagnosis. If we ask the patient, then we will come to know, okay, very likely we are dealing with some monoclonal antibodies also. So these are the couple of differential diagnoses we should keep in mind whenever, if you have all these 4 points, if you do not have, exclude this first 4, then the final diagnosis will be, yes, you are dealing with antibody against high frequency antigen. Now, as yes, whatever you can do for this patient, first of all, first question is whether this antibody is going to harm this patient or not. So check whether this antibody is reacting, is clinically significant or irrelevant antibody. If it's irrelevant antibody, forget about this antibody, at least for the patient management point of view, or you can give any transfusion to this patient if you find AHG cross matches are compatible with tube or something. So whatever reaction pattern we can see, whether this can cause hemolysis, what is strength, what is the reactivity, whether this antibody reactive with the enzyme treated or enzyme not treated, is there any difference? All these, the background information about this antibody helps in getting the final conclusion. And like I said, what options we have for, so before we jump to the reference lab, we have to find out the some solution for this the patient, because we have to we are answerable to the patient management as well. So what options we have? First information we have to share, okay, whether this is a clinically significant antibody or not. If it is a real problem, or is a risk in the transfusion, we can always check with the family donors, whoever available. And sometimes actually like 25-30% of cases, you will find a family donor who is incompatible as well as eligible for donation also. If it is rare blood type, then we immediately have to convey to the physicians. This is going to be a tough task. If we may not have a donation or donor available in India, we may have to get from outside India and so on. So autologous transfusion could be kept as an option for this patient. So all these the management related information, we have to share with our treating doctors. So now when we have a case of antibody against high frequency antigen, how these centers like IBGR or NIH or whichever the reference lab, what do they do? So like first they start with this information. Autologous control is auto control should be negative, pattern or the reaction strength, patient clinical history, or the technique and the methods what all has been used. So and finally they will have two information, whether antibody against high frequency antigen or complex antibody mixture, which means multiple antibodies. So first do phenotyping for all these the routine antigens where serology available. So in India, at least we have limitation of serology also, but if you go some other center, there are a lot of different antibodies available, like Diego also serology available, Lutheran also serology available. There are many others which we don't do serology, but yes, you have anti-sera available. Sometime commercial, sometime patient derived, but you have anti-sera available. So these centers, they do first level of serology test, and couple of null you can rule out from this. Say if you do RHKL typing, you can rule out your D dash dash RH null. All these the rare you can rule out from this. You can rule out Duffy null, you can rule out U negative, you can rule out KID null, Seleno. All these you can rule out from your basic phenotyping itself. And our phenotyping, like I said, has a limitation, but international phenotyping, they have a good number of anti-sera available. In fact, I just want to, this is just maybe out of the contest, but there are people ready to give anti-sera to us so that we can do more typing. People means there are some blood centers like from Argentina, Malaysia, Spain, and they are ready to give anti-sera like Diego, and like Argentina is ready to give one bag of Diego antibody, like one bag, so that we can test our people for Diego antigen. So there are a good number of serology available. We have a limitation, but outside country, there's a lot of other can be tested for serology. So another thing, this is first level of phenotyping, serology. Then the second is, like I said, they keep a lot of null cells preserved. So they have some rare cells preserved. So like if I now this particular case, which I have the crib antigen. So this patient is crib null. So what I will do, I will preserve this crib null cell. So this is my one null cell available or crib negative cell available. If I have the Duffy null, I will preserve this Duffy null cell. If I have kid null case, I will preserve this kid null, U negative. All these null cells they preserve in their labs. And whenever you have a keep the next level of testing is checking with the null cells, so, or the select cells, right? These null cells. So with the help of these null cells, they could find out, okay, which particular blood group system we are dealing with. Otherwise, before this, you are just blind. It could be Cartwright, it could be Cortet, it could be Lutheran, anything. So with the help of null cells, they get to another level of next level of conclusion. Okay, I am dealing like in this case with the help of Kromer null cell, they could find, okay, I am dealing with Kromer blood group system. So these are the null cells which they preserve, but we have to be cautious. If these null cells which they have preserved, it has to be of same ABO type, right? So because null cells are always from the patient or donors. Another problem could be if there's an underlying antibody, you will see the cross reactivity. So these are the cautions you have to be careful at this point of time when you use null cells. The moment you found a negative with the null cells, yes, you are dealing with this particular antibody. So this is all about serology. Next level is your molecular testing. Molecular testing nowadays mostly they go by in India still we do SSP PCR, but in other centers they go by sequencing. So they have the target based sequencing has been done like Kumar ka target or Colton ka target, Diego ka target, all these has been done. But in NIH Mumbai, they have developed a very good method of SSP PCR based to do this target based PCR to find out which particular antigens we are dealing with. So next level is your genotyping and the molecular level of testing. So these are the different steps of any reference lab. How do they will get a conclusion of which particular case they are dealing with, starting from your serology testing, antigen phenotyping, then null type, and then last is the molecule level of testing. This is some basic information what we found in our lab from last 4 or 5 years. So we have detected D dash dash, which is RH17, 5 cases we have in last 4 or 5 years. We had one RH, and it is just for your information, because most of us are from South India. NIH has, I think, unreported, but they have found that D dash dash is more common in South Indian population than the North Indian population. We have seen many cases coming, not many, like all these 5 cases coming from like 2 from Tamil Nadu. One case came from Andhra for a treatment in Bangalore. One case was from Bangalore itself. So like this is comparatively common than North India. This is NIH information. We had one case reported RH29, which RH null from Hyderabad. Now we have 2 INB cases also. We had one interesting case, Cartwright. This Cartwright, a negative case, YTA negative case with the KID A antibody. This was the hematological the case, and then we could not get any transfusion for this patient. And this patient, we were transfusing only KID A negative to this patient, but because of this antibody, patient had the rise in hemoglobin, but again destruction of red cell happens after some time, and this was happening in this patient. So this, but interesting is now after we started doing genotyping, we found one donor, female donor, who is YTA negative, so Cartwright negative, and this patient's, I'm not sure, one sibling and 2 in the family member are also YTA negative in this case. So we have reasonably 3-4 number of YTA negative cases in our list. There was one ENA negative case. Just for your information, ENA is a part of MNS blood group system. We have a very interesting U negative case here in Bangalore. This patient has multiple antibodies apart from this U as antibody as well. This patient is, reported as a U negative 4 or 5 years ago. This was a case went to Manipal Hospital for orthopedic surgery. They couldn't transfuse anything. They couldn't do any surgery for this patient. Also, this sample was referred to NIH Mumbai. They've detected couple of antibodies apart from this U negative. Currently, this patient is admitted again at Manipal Hospital here in Bangalore with a very low hemoglobin level. And then we are in touch with IBGRL again at NHS UK to send 2 units for this particular patient. Whether it will happen or not, let's see what happens. So this was a U negative case. We have one donor who is seleno negative. Tumor I just described about this case. We had one African patient who was taking treatment in Bangalore, and we found this patient, actually this patient, a female patient, Duffy null. We had a JK null, like kid null patient. And the moment I put this information in some WhatsApp group, I got 2 more information from different parts of the country. Somebody from Odisha reported, yes, they also found a kid null case. And Dr. Chitra from Kottayam called me after a few days when I put, and they also have a kid, yes, kid null case. And fortunately, Dr. Chitra could find one family donor also. So if you see now in India, we have 4 cases of JK null. But if we go by literature, JK null is common in Polynesian population, which is your Pacific islands, like natives of Australia, New Zealand. Those should have a JK null. But very interesting that we have 4 cases of JK null in India. 2 of our cases are still under investigation at NIH. So with this information, we have started this rare donor program, you can say regional program, for Karnataka, or with the help of government of Karnataka and NIH Mumbai. But this is anyway just a beginning. We started last year. It is actually a decades project, not only a year's project. You start now, but next coming generation will see the effect of this program. So what do we do in Bangalore to develop a rare donor registry here? So our target are to get donors who are repeat donors willing to come back again when we call them. So we and should be of O group. So we give this first of all information or education to the camps in form of some IC materials, some studies, charts or something to the camps where we go repeatedly. We have a good relation with the companies, good relation with the organizers and so on, so that whenever we go back to this person, we should have some connection. We should not get lost. Okay, whether this after putting this lot of efforts, we don't want to lose the donor. So first level is IC information or education at the level of camp. Then we ask people to, whoever is interested can register. We select O group donor from this. RHKL typing we do for all the donors, but after this RHKL typing we do for all the donors. From this RHKL, irrespective of the ABO type, all R2 we do extended phenotyping. So if any patient develop NTE plus some other antibody, we will have donor available. So this is something we do for and small k negative if we found, again we do extended phenotyping. So we do extended phenotyping for O donors and then the repeat donors. This extended phenotyping, whatever we can do here. And for these donors, we send for genotyping, as of now, we send to NIH Mumbai, and they have again one panel of genotyping which cover Cromer, Colton, Cartwright, Sienna, and all these rare ones in their panel, and they share this information. We have a common Google sheet which phenotyping and genotyping are kept together for our information. This is our information or the data from last year. We started doing sometime in March or April last year. As of now, nearly 200 samples we have done extended phenotyping. And this is information 2 antigen negative, 4 antigen negative, and so on, whatever we have. Coming to the conclusion, yes, we understand like every life is important. Though, yes, understand any like getting a rare is actually rare and it's really time consuming and a lot of efforts will go. But every life is important. We cannot just ignore these patients who have some rare phenotype. So we have to have the program available to have these rare patients as well who has a rare type. We cannot just leave, okay, you do whatever you want to, or we cannot just leave to the physician whatever you want, you can do with this patient. So India should have a rare donor program. Of course, attempt started by NIH Mumbai, and this program is going on. Unfortunately, there are some administrative orders at the NIH as well as health department at the central level. Still, it's not fully functional, but we hope that it will be fully functional in some point of time. So the requirement is definitely is we have to have the networking together like a national level. First of all, Kerala should talk to Bangalore, Bangalore should talk to Delhi. So all these networking, if we have, we can work together. My humble request to all the students or whoever are deal with the primary level of IH testing, whenever you have a pen reactivity, whenever you see any pen reactivity, pen agglutination pattern, these cases, please do not ignore this case. I understand it's very frustrating for a lot of, but remember this case, you are not dealing with this case, you're dealing with the future cases. So once you will not be able to find out with this case, but the later in coming years, this information will be useful. So we have to have a database available. What are the common rare phenotypes for our population? So I think that's all I wanted to share. Thanks you again, and happy Onam to everybody. And over to you, Atira and Abhishek, for any questions if anybody has.
Yeah. So thank you, Ankit. So before we formally end, so one is somebody has asked whether once you realize that this is not solvable at your level, did you directly approach UK or there are options available in India? That is what somebody has asked.
So in India, NIH is definitely an option. Any reference lab, I keep on hearing from people that, oh, NIH take months or something. If you go to UK, it will take years, I tell you. So if NIH is months, UK and I mean IBGRS years. So all these reference labs take long time. So since we all are I mean, at the hospital centers, or we are dealing with the patient directly. So we have to have a primary information available, whether the family donor is compatible or not. This we can do immediately so that we can solve the problem of this patient right now. All these reference lab, they are not the clinical lab. They will not give you answers immediately. So if somebody is thinking I send a sample today to NIH and tomorrow they should reply, it's not going to happen. It will take months. So it's frustrating. Definitely, I understand and I agree. But it's that. So NIH is one option. NIH does almost everything which IBGRL UK can do. In fact, if you ask me, NIH has developed very good panel of genotyping, which cost of this genotyping is 1/10 of the commercial cost, even less than 1/10. And it's a fantastic panel which they have developed. This answer is satisfactory?
Yeah, that is what they want. I think they want to know whether we have to, first of all, is there an option in India is what they wanted to know. The second,
and in Bangalore also, we are trying to set up the, some sort of genotyping for the common ones, like what we have seen, INB, Indian Blood Group System, and Cartwright. And these are the common which we don't have serology available, but we need only genotyping is the answer. So we are trying to set up this SSP-based PCR in Bangalore also. So at least some level, if you don't want to send NIH, you can send at least some sort of serology and some genotyping we can do in Bangalore also.
Thank you. I think that answers their question. The second thing they have asked is, like whenever we suspect that the antibody could be against a solute or a whatever preservative media, so immediately do you change the platform and see, or you try to use it in the same platform? Because
immediately, this will not take long. Why should you
not like
depend?
that. So I think what they meant is, see, for example, say there is say antibody against a list or something. So if you want to show that, do you try to eliminate lists from the same platform and use, or entirely go to the different media platform? That is what they mean, I think.
When you are dealing with this, you don't know whether you are dealing with this reaction is because of preservative list or something else. So as simple as go by tube. Do the testing by tube and use proper only normal saline for your washing and everything. And you can also use sometimes we do the same thing. Use a fresh cell. Fresh cell means don't use a preservative cell. Use a preserved cell. Use a common your O cell in whatever you prepare in house. So the fresh cell. Sometimes you see the preserved cell also give false reactions. So changing your platform definitely helps you. And this how to change, when to change, and from which to which, this will come from your experience. And sometime you will come to know, okay, this could be because of gel, I should move to tube. Tube is the best to rule out any suspected false reactivity.
Okay, nice. So that clarifies that. Another thing I wanted to ask from my side, see, once you suspected an antibody, you tried, I means IBGR or whoever, they tried against a null phenotype, and they found that, okay, this is compatible with null phenotype, means that probably we are dealing something with here. Now you have an antibody which is not characterized, in the sense it is probably against an antigen which is also not characterized. So how do they link these two things?
Okay, so if I understood your question, so I just try to answer again. Say if we give again the example of this case. So first they had this antibody and they found first level is this antibody belongs to Cromer blood group system, correct?
Correct.
Now the moment you know, okay, this is Cromer, Cartwright, Colton, anything. Now the second step is molecular test, like sequencing. If you know the sequencing, then in sequencing you will come to know, okay, what kind of mutation is has. So now in sequencing, what you have now, I have a patient ka sequence available. Now I have 21 antigen described in the Cromer system. All these 21 sequence I have in my list. Then I will try tally with the existing 21. Suppose now tomorrow from Puducherry you have a Cromer blood group system, which is you want to say CRIP, India Puducherry. Now, for example, this first information has to be Cromer blood group system. Now, from sequencing, they will come to know they have sequence available of 21 antigen till IB. Now, once one information is abhi Cromer hai, but this is not from any of the sequence available. This will give them a hint. Yes, this is 22nd of Cromer.
So
Is this correct?
synthesize an antigen using recombinant technology and then try to use it.
Sequencing. Then the
Fantastic.
sequencing gives them the answer.
I
This
hope
is novel
that
or
is
not.
clear to all those who are listening. So this is something. So he was immediately telling that it takes 1 year, obviously, because of these many complexities involved. So we are dealing with something that we don't know. So we have to sequence it and create an antigen based on the sequence, and that too by recombinant technology and all, which will obviously take time.
And the sequencing is not difficult, Abhishek.
Sequencing is fine, but creating an antigen out of that sequence is not everybody can do that.
Yeah, of course, of course. No, no, Abhishek, is not very difficult. If you want to make your sequencing panel, you can. There are good number of companies available, and this data is also available. So this, I ask this data. I think it's public. So I say CR 1, 2, 3, 4, 20 ka. What is the sequence? This data is available. I think it's public domain also. So if you want to develop your panel, you have to have this sequence available. Ask to these any these bio engineering companies, so they will develop a panel for you. That's what we are planning to do in Bangalore, and that's what NIH did.
Fantastic. Dr. Atira, I think I can see one person raised hand, Basit, if you can unmute him.
Okay, okay, sir.
Dr. Basit, I think you can unmute yourself and try to speak.
Send samples to it here for further testing. I have had mic problem. Okay. Okay. So
So please type it.
Acha. Okay. So he. So whoever has written, yes, you can always send sample. I'm not sure. Is it disturbance from my side or somebody else? So I am not sure who has asked this question, Dr. Basit. So yes, you can always send sample to us. We'll be happy to do testing, whatever we can do. But just for your information, as of now, we have a limitation serology only till certain level of serology we can do. Maybe in coming few months or maybe year or something, we should be able to establish something related to molecular genotyping in Bangalore also. Any
Somebody has asked an interesting question. So, for example, whenever we find an antibody, we actually what we do is we test against a null phenotype to first fix it to one of the blood group system. Correct? So their query is, if at all, I mean, the null is not established or something like that, or something like a GATA mutation or something. It's not a true null phenotype. Then it's possible that we will not be able to do it, right? Or is there another way to do that?
I think sequencing will solve a lot of problems.
Okay.
I mean, questions. So whatever you are not able to identify from serology, even basic SSP, PCR, sequencing give a lot of information. Like you have a sequence of this person available and you have a data available. So compare your patient sequence data with the existing sequence data. This will almost solve.
Yeah, so that will create a null phenotype and that can be utilized to the this one. Fantastic.
Aditya,
Sir, yeah,
I think
sir,
we have covered
if I may,
everything.
Dr. Abhishek, you were asking about the sequencing, right? The sequencing that was used,
Tommy, you are
that
talking.
they used is also mentioned in our report. Yes, sir. In the report, so they have mentioned that they tried to identify the sequence in that particular database, but it was not available, which brought them to the conclusion that it is possibly a. So like sir said that it is a common, I mean, a free use database. That's the one that they have used. It's mentioned in our report. So that's the one that they had referred to.
I'm not sure who was talking.
Good afternoon, sir. Sir, Aditya here, sir. Can I ask a doubt, sir? Small doubt.
Yeah, please.
Sir, once we have characterized or pinpointed the system, antigen system, blood group antigen system, then we go for a sequence-specific primer just to correlate this. Is it just to correlate the sequence with the existing informatics data? After that, we go for a actual sequencing of the between the primers of the DNA. And is it after that we engineer the we take that sequence, add in the nucleus, make the nucleus make the cell grow, and then let the cell create the protein and then characterize the protein? Does it go like this?
Okay. First part of your question I understood. Second part of this, I don't know. This going to cell and growing in the cell and all, I have no idea about it. But okay, I just tell about. So there are two techniques for in genotyping. One is there are several techniques in genotyping. One is the simple basic one, which is SSP PCR base. In SSP PCR base, you have to have a primer available. So you will have a primer for but sequencing is different. You will have a primer for, say, for INB. I don't have anti-sera, but I have a primer available. So what I will do, I will check my sample with this primer. And if there is amplification happens, means this is positive for INB. So this is SSP. But sequencing is, it is not PCR. Sequencing is, we all know any DNA will have this nucleotide A, T, and G something, right? So this what sequencing will do, any sample you put on the sequencer, it will give you this combination of ATCG, whatever, and n number, it will keep on going. Then you compare this sequence with the existing database and then find out which this sequence belongs to which particular data. This is sequencing, which is NGS, next generation sequencing I'm talking. So we are dealing with two different methods of genotyping in your Excel like molecular lab. One is SSP, another one is sequencing. Fortunately, NIH Mumbai has both. And any lab like NIH, they will go by their protocol. So first level, they will do something for SSP. Next level, they will go for sequencing and so on. Is that what you are looking for, Aditya, or something else?
Yes, sir. Yes, sir. The first step is the first part of the question is clear, sir. So, sir, once we have a sequence, so we reverse engineer it, like we use that sequence to create the protein.
Yes.
But
yes.
Okay, you can do that. I am not aware about it. So if your sequence available, you can generate the protein, and then you can generate the antigen, and you can generate the it's a typing method. Am I right? That's what you are thinking?
Yeah. So
yes.
so you don't have to have a cell. If you have generated proteins or antigens, they can be embedded onto some neutral substances. Basically, you have to show the agglutination or neutralization reaction. So once you have the antigens, you can coat them onto rubber beads or something also, and you can do that. You don't have to grow the cell with the antigens.
Okay, sir. Okay. Thank you, sir. Thank you.
So just Aditya, just to add here is this will go. This is the way anybody, I think, develop any, testing method. Unfortunately, we do not have a lot of testing methods and the platforms available for red cell genotyping.
Yes. Thank you, sir. It was very keen, and with everything you have explained, sir. So much interest. Thank you so much.
Any other question, Abhishek?
We don't see anything here. So if so, of course, Dr. Ankit is always available with your mail or whatever, so you know where to find him also. So I take this opportunity to first of all congratulate him and also thanking for him to taking time and doing this for everybody. Thank you, Dr. Ankit, and wishing you all the accolades for your future work as well as things that you like to accomplish. Thank you one and all for joining. We had a very good participation, in fact, and the good thing is I could see even few people out of the group, group in the sense out of transfusion medicine fraternity itself joining. So that's a wonderful development, and thank you. Over to you, Dr. Atira.
Thank you, Dr. Ankit, for an excellent and enriching presentation. Thank you, Dr. Abhishek, for chairing this highly insightful and valuable session. With that, we conclude today's webinar organized by the Transfusion Medicine Academic Society. On behalf of TMAS, we express our sincere gratitude to our chairperson for the session, Dr. Abhishek, and for our speaker, Dr. Ankit, for their contributions, and to all the attendees for being with us today. We look forward to seeing you in the upcoming TMAS sessions. Thank you and have a wonderful day.
Just one doubt, Dr. Atira, are we recording this session and are we making this available?
Yes, sir. It's already been recorded. We'll be sharing by tomorrow or day after tomorrow.
With Dr. Ankit's permission.
Yeah. Okay. Okay, sir.
Thank you all.
Okay, thank you, Abhishek. We can
Thank
close it now. Thanks, Atira. Thank you so much.
Thank you so much, sir.